First of all, I just want to say it's a pleasure being here. Yesterday was a great day. And the first part, I'm going to talk about the larger picture of an anatomy of an epidemic. And what I did in that book, which Steve is talking about, is I really asked a question that we need to ask but isn't often asked. And that is, how do psychiatric medications affect people's lives over the long term? So we know that psychiatric drugs, like all drugs, they get approved because over a very short period of time, 6 weeks, 8 weeks, maybe they knock down a target symptom of a disorder better than placebo, and that is seen as they're effective. But people, of course, stay on these drugs for years. You're even told they fix chemical imbalances in the brain, and that's why you have to keep on taking the drugs. So I asked this question: how do they affect people over the course of 5 years, 10 years, 15 years, 20 years? Which is, of course, the answer we really want answered. We don't just want to know about short-term symptom suppression, we want to know about that longer story. So I'll talk about that and sort of build on what I spoke about yesterday, and maybe for 30 minutes. And then the second part is this new book, Psychiatry Under the Influence, really goes to the theme of this conference, the real truth about health. So you're going to hear a story which you don't hear in the media, and then the question is, why? Why does our society organize itself around one narrative, and then when you go to the science, you find actually a very different narrative found in the scientific literature? So why isn't that narrative the one that the whole population knows and is the organizing principle for our social response? And I spent a year as a fellow at Harvard studying institutional corruption. How do institutions in our society end up betraying their public mission? They asked me to look at the institution of psychiatry, which means the American Psychiatric Association and academic psychiatry. In what way did they, in essence, become a corrupt institution in which they put interests of pharmaceutical companies and their own guild interests above their duty to the public? So that'll be the second half of this talk. And I'm going to wing it, and hopefully it'll be okay, but no slides. So let's just go to the story about anatomy of an epidemic and the narrative that generally drives our thinking about psychiatric medications. The larger narrative in our society goes like this. Prior to 1955, we lacked therapies that would prevent people in psychiatry, that would prevent people from becoming chronically ill. Then we get a new drug, which you know as Thorazine, arrives in asylum medicine in 1955. And according to the narrative this kicks off a great psychopharmacological revolution, this great advance in care. And now listen to the names that are, when this drug arrives, it's known as a neuroleptic, meaning taking hold of the nervous system, or it's known as a major tranquilizer. But then very shortly, the drug is renamed in psychiatry. And they say this drug is not just a tranquilizer, it's not just taking hold of the nervous system, it is an antipsychotic. So what do you hear in that word? Antipsychotic, like an antibiotic. It's a drug that is a specific antidote to psychosis. And that drives the thinking of people in the field. We now have an antidote to psychosis. And then what do we get? Antidepressants. Same thing, that these are an antidote to something biologically wrong that causes depression. It's a specific drug. And then we get anti-anxiety agents. And all this happens in the 1960s. We now deinstitutionalize, we let people out of the mental hospitals. That is credited to the drugs. It's actually not true, but it is credited to the drugs in this narrative. And then in this narrative of progress, it goes like this. In 1987, Prozac arrives on the market, and this is the first of the second generation of psychiatric drugs, which is said to be so much better, safer, and more effective than the first. Prozac is an antidepressant. It's known as a selective serotonin reuptake inhibitor. This drug is said to be so much better than the old tricyclics and the old monoamine oxidase inhibitors. Then we get new antipsychotics, which are also said to be so much better. And in 1998, U.S. Surgeon General David Satcher, sorry, I just had that moment where the brain wasn't working. Anyway, U.S. Surgeon General David Satcher, he wrote a report on mental health, like a 400-page report, and he said this. He summed up this history of progress. Prior to the arrival of Thorazine in asylum medicine, we lacked treatments that would prevent people from becoming chronically ill. Now we have a vast array of drugs and therapies for very well-defined diseases, and it helps people live normal lives. That's the story of progress. Now, this is coming from your top doctor in the United States, and it's a story of progress, right? Drugs that are specific antidotes, helps people lead ordinary lives, and it prevents chronicity. Okay? That's the story in writ large. Oh, and by the way, as part of this story of progress, what happens do we learn about in the 80s, early 90s? We hear that these drugs fix chemical imbalances in the brain. So we hear that that depression is due to low serotonin. You take an SSRI at up serotonergic levels, and therefore it's like a treatment like for insulin for diabetes. This is part of this narrative of progress. Now just focus for a moment on that story, that chemical imbalance story. That is telling of an extraordinary medical discovery. That is telling us that we have discovered the cause of schizophrenia. We have discovered the cause of depression. We've even discovered the cause, apparently, of ADHD and all these other disorders. We have identified the molecules that say why this person has a broken brain, and we can fix it. If that's so, there are few things in medical history as profound a leap forward as that. Think about how complicated the brain is, right? Unbelievably complicated. And researchers have identified the molecule that's amiss in these things, and we can fix it. That is extraordinary of a story of extraordinary leap forward. Okay? And that's the narrative, really, that has been told to us as a people. And it's also a narrative that somewhat was told within psychiatry, too. So what I did in this book, Anatomy of an Epidemic, to begin to put that narrative under a microscope was do this. Okay, Prozac arrives in 1987, right? This is the first of the second generation drugs. It's also the time when we as a population really begin to embrace the use of these drugs. So in 1987, we as a people in the United States spent about $800 million on psychiatric drugs. We're now spending about $40 billion a year on psychiatric drugs, 50-fold increase. You know what percentage of Americans of all ages now take a psychiatric drug on a daily basis? Any guess? It's 20%. So 1 in 5. That tells you how prevalent these become. We, of course, have children. I think it's the latest data I saw on children. About 13%. No, excuse me, 13% have been diagnosed. It's about 10% now on a drug every day. That's from 6 to 17. So we're making great use of these drugs. It's really changed our society in many ways. So the first thing I did to look at this story of progress was just look at the number of people on disability in the United States due to mental illness. Now, if the narrative is true, you should see, if anything, when you have a great advance in care, right, you should see the burden of that illness either go down, you shouldn't expect it to go up. It should either maybe stay the same for some reason, but really you should see it go down, right? Especially if the story is that this helps people live normal lives, helps them function. So how about disability rates in the United States? Well, among adults, in 1987, there were 1.25 million adults on disability, meaning they were getting a disability payment from the federal government because they couldn't work. There's two types, there's SSI and SSDI. And they were being declared eligible because they had a mental illness. And what is it today? Anybody know? If you were here yesterday and listening, you know it's 5 million people today. So during this time, since Prozac and these better drugs arrived on the market, rather than seeing the burden of mental illness, at least as measured by these government statistics, go down, we're seeing a rising number of people on disability. By the way, the disability numbers are being driven by affective disorders, depression, and bipolar. That's what's really driving the disability numbers. How about children? Before 1980s, we didn't medicate our children much, right? It's a new thing. We now raise our kids in a different environment. In 1987, there were only 16,200 children in the entire United States whose families or foster care parents were receiving a disability payment due to mental illness. 16,200. Now, of course, since 1987, we've increasingly diagnosed youth with ADHD and bipolar and depression. So how many disabled kids today on disability? It's about 700,000. So during this time of second-generation drugs, we're seeing this rising disability numbers. By the way, if you follow those kids who get on disability as children, when they hit age 18, it seems about 2/3 go on to adult disability right away. So what you see is a new career path that has opened up in our society, where you get diagnosed and said to be mentally ill early on, and that becomes sort of your lot in life. Now, after I published this book, people said, you know, the reason you have such a disability problem in the United States is because you don't have access to health insurance. It's sort of a Darwinian society, and people are going on disability because they can't get welfare or they can't get health insurance. So that's how it was explained away. So since then, however, I've had the chance to look at disability numbers in countries that have very good access to health care and have very good social nets. Sweden, Denmark, Germany, Norway, Germany, etc. New Zealand, Australia, every single country I've looked at that has adopted this paradigm of care has had a remarkable increase in disability due to mental illness. In Australia, it's about 4 times as high as it was 20 years ago. New Zealand, about 4 times as high. So what you see is this disability burden is happening in every society, at least Western society that I've looked at, that has really adopted this paradigm of care. Now, those disability numbers, I don't think, prove anything about the long-term merits of drugs. They just raise a question. Why, as we use these medications more and more, are we seeing more disability? So the next thing I did in this book, and as those of you who were here yesterday, the next step in this book was looking at this chemical imbalance story. Is it true? Have we found that depression is due to low serotonin? Have we found that schizophrenia or psychotic disorders are due to too much dopamine in the brain? There was some thought that ADHD was due to too little dopamine, that sort of thing. So I looked, and the first thing you find is that starting in 1980, there was this regular repetition of pronouncements from the American Psychiatric Association that that is so. We have found that depression is due to low serotonin, and these drugs fix that problem, like insulin for diabetes. They bring it back into balance. That's what you were told. And by 2005, the American Psychiatric Association did a survey, and 75% of Americans now know that depression is due to low serotonin. A later survey said 87% of Americans now know that depression is due to low serotonin. And in 2005, you even see a marketing campaign by the APA to say, psychiatrists are doctors who bring your chemistry back into balance. They're specialists in this function. But now you go to the research, and you look at, do people with depression, diagnosed with depression, prior to going on this drug, do they have low serotonin? And this research, and then what you find is this. The whole theory arose because of an understanding of how drugs act on the brain. So let's take it like a selective serotonin reuptake inhibitor. Real quickly, I know this is going over things yesterday, but we'll just go it real quickly. How do neurons communicate in the brain? You have a presynaptic neuron that releases that molecule, like serotonin or dopamine, into a tiny gap between neurons. This is called the presynaptic neuron. It releases that molecule. Then that molecule, like say serotonin, which we call a chemical messenger, binds with receptors on the receiving neuron, which we call the postsynaptic neuron, and we say it fits into those receptors like a key into a lock. You've all heard that, right? As part of this chemical messaging, what does the brain have to do? It has to remove that chemical now from that synaptic cleft, right? So there's going to be a pulse. The chemical is released. It binds with receptors on the second one, the postsynaptic neuron. That causes that neuron to fire. And now it has to have a way to end that message sharply. And so now it removes that serotonin from the synaptic cleft. And it does it in one of two ways. It either goes back up into the presynaptic neuron, or an enzyme comes along, metabolizes it, and the serotonin metabolites are carted off as waste. So what does Prozac and the selective serotonin reuptake inhibitors do? They block the removal of serotonin from that synaptic cleft, so it can no longer go back into the presynaptic neurons. It stays in that gap longer than normal, and therefore, theoretically, ups serotonergic activity. So once people came to understand that mechanism, they said, well, maybe the problem is low serotonin then. You see what they're doing? They're hypothesizing the low serotonin based not on an understanding of what's happening to people, but on the basis of the mechanism of action. This goes back a long way, but in the 1980s, they begin investigating this low serotonin theory of depression, and what do they find? They find that prior to going on drugs, they can't find any serotonergic abnormality. This was first reported by the NIMH in 1983, And then after Prozac comes to market, there's a flurry of more research, and they just never find a lesion in the serotonergic system as a cause of depression. And so even while the public is being told about drugs fixing chemical imbalances, you go, for example, to the 1999 textbook of the American Psychiatric Association, they said, we didn't find it. Okay? And they even say, they sort of make fun of the origins of the hypothesis, because they said, just because a drug has a mechanism of action, there's no reason the pathology is going to be the opposite of that mechanism of action. Anyway, you find it again and again. Kenneth Kendler in 2005, he says, Kenneth Kendler is one of the world experts in chemical imbalances. He's been researching this for a long time. And here's what he says in 2005. We have hunted for big, simple neurochemical explanations for these disorders and have not found them. Okay, so that story is a false story. So you see that the story that led us to embrace these drugs, in fact, is not scientific. It was a hypothesis that was investigated and not found to be true. But there's another kicker to this story. They did find, after you go on the drugs induce the very abnormalities that are hypothesized to cause the problem in the first place. Now, why is this? Think about this. Let's go back to these drugs. You have an SSRI. It blocks the reuptake of serotonin in the brain, right? What's that doing to serotonergic activity? It's putting down an accelerator, supposing upping serotonergic activity, right? That's what we all hear. Well, what do you think your brain does in response? The brain, being this extraordinary neuroplastic organ with all these feedback loops, it measures that, and all of a sudden a signal goes out and says, uh-oh, serotonin is staying too long in the synaptic cleft. That's a problem. We're now out of balance because of the drug. And so now what researchers have said, the brain now tries to compensate for this perturbation of normal function. It's trying to adapt, and it's trying to compensate in order to do what? To maintain what they call a homeostatic equilibrium, normal functioning. So if you put a drug in that ups serotonergic activity, what does your brain do? It dials down its serotonergic activity. And it will dial it down in two ways. The presynaptic neurons will put out less serotonin than normal. Now, I'm not quite sure how long that compensatory adaptation lasts. It seems like the research is a little bit confusing on that. But that's one way. In rats, by the way, you end up depleting the forebrain of serotonin if you put them on an SSRI. But more well known is that the receiving neurons, with the receptors for serotonin, they will decrease their number of receptors on their cellular surface for that molecule. They're becoming desensitized to serotonin. And again, you can see why. You have a drug that acts as an accelerator, your brain puts down the brake, okay? And this is the way to understand how the drugs work. And you can read a 1996 paper by Stephen Hyman, who was then director of the NIMH, and he lays this out. He says, here's how psychiatric drugs work. They perturb normal function. Your brain then tries to adapt to it. You get long-lasting neuronal changes, and then he says the brain is now operating in a manner that is both qualitatively and quantitatively different than normal. So we have an image of the drugs as normalizing drugs. In fact, they're abnormalizing drugs. And just to go back to this, remember depression was hypothesized to be due to a biological deficiency in serotonin in that system. They found that prior to going on the drug, you don't have that deficiency. But after you go on the drug, your presynaptic neuronal release of serotonin is disturbed, abnormal. And physiologically, the postsynaptic neurons now have fewer serotonergic receptors than normal. So you've driven the brain biologically into a subserotonergic state, which was the very state hypothesized to cause depression in the first place. Now, it's really pretty easy to flesh this out in the literature, but you can see, this is a Real Truth About Health conference, nobody going on an antidepressant is told that story, right? Nobody. It's not in your advertisements. Even most of the doctors don't know about it. Once you understand this, however, so now let's go back to this image. You go on an SSRI, it puts down the accelerator. Your brain puts down the brake. Now you take the accelerator away when you're trying to come off the drug. You see why you have a problem? Your brain has become adapted to the presence of the drug, and now it's missing that. And this is seen as why you're having so many withdrawal symptoms. So that's one thing. Two, is this going to renormalize in the absence of the drug? Is your brain going to renormalize its receptor densities? The answer is we don't know. There's some worry that it will persist, and even if you come off, it won't renormalize, and then there is some sense that it will. And it seems to me that sometimes it does, sometimes it doesn't, but we really don't know the answer to that question. So you can see once on, going off is tough, but now let's look about the long-term functioning of your serotonergic system. You got a drug doing one thing, your brain trying to compensate for that. You think that's going to lead to ideal functioning of that system? It doesn't, basically, you see. And this is why you see so many side effects. That ability to compensate for the perturbation is not perfect. So that's a conception of drugs. Once you have this conception that you can now take as you look to see how the drugs affect people over the long term. Okay? And I think you can see two things, why coming off is so difficult and why maybe you're going to have problems over the long term as you sort of impair the functioning of this pathway. Now, yesterday what I talked about is the antidepressant literature. I'm not going to go over the data again, but what you find when you try to see when you flesh out how antidepressants affect people's lives over the long term, you find this. Prior to the use of antidepressants, the research showed that depression by and large was an episodic disorder. With time, people would recover from an episode. They would recover to what is known as euthymia, an absence of symptoms. And then if we follow those people for 15 years, we'd sort of see a spectrum of outcomes like this. About half of people would never become depressed again, or at least not seriously enough to be rehospitalized, and these are studies in hospitalized patients. About 30% would seem to have an episode every 3 years, 2, 3, 4 years. And so over the course of 15 years, they might have 3 or 4 episodes. And it was that group that also showed, well, listen, this is an episodic thing. It does come back in a number of people. And then maybe 15 to 20% would become chronically depressed. But remember, this is in a group of patients that are hospitalized for depression. These are severely depressed patients we're following long term. Then what you find real quickly is once the drugs are introduced, people notice something odd. I'm talking about doctors. Doctors who've been treating depressed patients before the antidepressants came. Now they get a new tool. And now they're seeing a different course in their patients. And what do they see? Boy, my patients are getting better faster, but boy, are they relapsing back into depression more frequently than before. So right away in the clinical perceptions, you see a worry about maybe we're causing a chronification of the disease. Now you look at the course of depression today, it does run a much more chronic course. That's acknowledged. I'm talking about medicated depression. If you compare studies, if you find studies that go from 5, 10 years, and also look at functional outcomes. Are people working or not? And are they symptomatic? I will tell you, every time the unmedicated patients do better over the long term. They have less depressive symptoms over the long term, and they have higher functional rates, less disability rates. So what you see in that, and then, this is the kicker to this story, as this has become more and more, at least some people acknowledging this chronic course, that we're seeing in medicated depressed patients today, there's at least a few researchers saying, what's going on? And here's what they're saying. Just a few willing to go down this. These drugs, over the long term, induce the opposite effect of what they do over the short term. Because it's supposed to up serotonergic activity, it actually drives your brain into a lower serotonergic state. And maybe that's why we get these chronic conditions, because over the long term, they're causing these compensatory changes in the brain, the opposite of what the drug is supposed to do, and that's the problem. Okay? That's the story for antidepressants, and basically that's the story I could tell you for every class of drugs. I was going to do antipsychotics today, and one of the reasons, I know you're not so interested in antipsychotics, but one of the reasons doing antipsychotics is good is because in this narrative of progress, antipsychotics sit at the heart of this narrative of progress. They're the drugs that came in, made it possible for these crazy, mad, chronic patients in the asylums to come out, live fairly normal lives. In our society, generally it's considered heresy to say that anybody with psychosis or a diagnosis of schizophrenia could do okay off the medications. We have laws now increasingly that force people with certain diagnoses to take antipsychotics in the community. So if there's any class of drugs that should have a clear long-term benefit story in science, it's the antipsychotics. And real quickly, and then we'll sort of put this one to rest, you see the same paradox emerge in the scientific literature around antipsychotics. So what do you see? You do see some short-term effectiveness in terms of knocking down psychotic symptoms over the short term. That's there. That's why they get approved. But then if we go back to their introduction and we look at clinicians as these drugs are introduced, they say this, you know, boy, these patients are coming back like crazy. And they even invent, back to the hospitals. So they get treated with drugs, they go out, often they do throw the drugs away, and they say, boy, they're coming back to the hospital more frequently than before. It's like a revolving door syndrome. They even use this language. And then they say this, you know, it also seems like now when people relapse after being exposed to drugs, their psychotic symptoms are more severe than we used to see in placebo patients. And especially they'd say if people are on the drug, they stop the drug, we get really severe relapses. And real quickly, do you know how antipsychotics work? What they do now is they block dopamine receptors in the brain. It's like they're glue in that lock, so they thwart dopamine transmission. So what does your brain do? It ups its dopaminergic transmission. For a period of time, the presynaptic neurons put out more dopamine than normal, and then your receiving neurons will increase their density of dopamine neurons from anywhere from 30 to 100%. Okay? So now you become super sensitive to dopamine. Then there's 4 studies in the 70s funded by the NIMH that are meant to revisit the effect of antipsychotics on the long-term course of schizophrenia. Here's what they find, real quickly. They do a retrospective study. They look at outcomes, 5-year outcomes from a group of patients treated in 1947 at Boston Psychopathic Hospital with psychosocial care, no drugs. They compare outcomes of a group of patients treated in 1967 with psychosocial care plus drugs. And what do they find? Higher relapse rates, in other words, rehospitalization rates in the modern group, and much more important is much less adequate social functioning. They're much less likely to be employed, much less likely to be engaged with other human beings, in other words, marrying, having kids. And so what does this? Samuel Bachhoven says, if we're interested in long-term clinical improvement and functional improvement, we have to rethink these drugs. Then there's 3 studies funded by the NIMH during the 1970s, and basically they go like this. We're going to have one group that gets conventional care with drugs, hospital, and then we're going to have an experimental arm. And in this experimental arm, we're going to give them psychotherapy, psychosocial care, milieu therapy, and we're going to use drugs in this way, either not at all, or we're going to use them in a selective manner. If people aren't getting better after 6 weeks, we'll try to use low doses. So it's more of a selective use model. Each time, the outcomes were better for the experimental arm. So you'd see over the long term lower relapse rates and higher function. And each time you see the researchers go, if we're interested in long-term outcomes and not just short-term symptom suppression, we have to rethink this. And then in 1979, William Carpenter, who still today is a leading schizophrenia researcher, raises a really profound question. Now think about the data he has. He actually has 3 parts of data. He has the short-term data that shows you knock down symptoms better with drug than on placebo. Then they did studies designed like this. And these are the studies that are cited to justify long-term use of antipsychotics. You take people who stabilized well in antipsychotics, which isn't everybody, that's a good responder subset, and you would do studies where you abruptly withdrew the drug, half the patients, randomized studies, the other half you would keep on the drug, and with great regularity those withdrawn relapsed at high rates. And so what doctors said at the time, see, you take the drug away and the disease returns. Now we know today a lot of what we're seeing in that relapse rate is in fact a withdrawal effect. But it's perceived at the time as you take the drug away, the disease returns. So he has that bit of data, William Carpenter. He's at the National Institute of Mental Health. But now he has also this data showing it seems like relapse rates, in fact, are higher in drug-exposed groups. So what does he say? And watch this, listen to this. We know that once patients are on antipsychotics, they are less vulnerable to relapse if maintained on the drugs. That's the withdrawal studies. But he says, But we raise this possibility. What would happen if these people had never been exposed to antipsychotics and never undergone this change? We raise the possibility that these drugs are making people more biologically vulnerable to psychosis than they would be in the normal course of their illness. So you see here, here's where the alarm flag goes up, right? Because this is the target symptom. This is not a side effect. They're saying these drugs may be making people more psychotic than they would be normally. At that point, two researchers from McGill University, Barry Jones and Gil Chenard, say, we know what's happening. These drugs induce these changes in the brain that make the brain super sensitive to dopamine. Got all these extra dopamine receptors, and that's why when you come off, you're getting such severe symptoms. He says, but even if you remain on, you may get something called tardive psychosis, where because of impairment in that dopaminergic system, the people are going to become chronically psychotic. And he does a study, and he figures out that tardive psychosis seems to develop about 3% per year. After 1 year, 3% of people on the antipsychotics have permanent psychosis. After 10 years, it looks like 30%, and keeps going. So what the image that comes out is these drugs actually increase psychosis over the long term. And stop even thinking about all the side effects. There's all side effects. This is on the target symptom. Anyway, if you go forward, then the question is, that happens in the 1980s. Do we have reason to believe that this is so? We do get new drugs, or not so? Is that a false alarm or not? And here's what I'll tell you the data is. And I'll go through this real quickly. The World Health Organization, and the data comes from all different data points, okay? And my job as a reporter is just to find whatever data I can find that in some way has a bearing on this. And I wouldn't say that any one study is definitive. The question is, does the puzzle fit together? So we have a World Health Organization study that compared outcomes in 3 developing countries, India, Colombia, and Nigeria, with outcomes in the US and 6 other rich countries. The first one was 5 years in length, and the researchers found something odd. Outcomes were much better in the poor countries, particularly India and Nigeria. And they said, what's going on? And they said, particularly what's amazing is they concluded this after the first study. Living in a developed country is, quote, a strong predictor that you won't have a good outcome if you're diagnosed with schizophrenia. And this was actually the finding that got me interested in this whole field, because I'm like, why would living in a rich country with all our great medicine be a predictor you won't do well long-term with this disorder? So they hypothesized at this time that maybe the problem or maybe the reason for the better outcomes in the poor countries is the patients there are more medication compliant. They take their antipsychotics regularly. Now that's a valid hypothesis. If you think that medications are so essential, greater medication compliance should be associated with better outcomes. What did they find? They found in the countries with the 2 best outcomes, India and Nigeria, they used the drugs very differently. Acutely, not chronically. So they would use them to get them through that psychotic episode, then they would take them off. And in those countries, in those 2 countries, only about 10% of patients were maintained on drugs long term. So in those studies, what do you see? Better long-term outcomes where they're using the drugs differently. Anyway, we now have a lot of other research on this. We have the best long-term outcome study. I mentioned this yesterday, done by Martin Harrow at the University of Illinois. He followed 200 psychotic patients for 20 years. It's a naturalistic study starting in the 80s. Everybody treated with drugs in the hospital, then they're discharged, and now he just follows them at 2, 4.5, 7.5, 10, 15, and 20 years. What did he find? The recovery rate over the long term was 8 times higher for the off-medication group. They were also less anxious, much more likely to work. In fact, there was a pretty good work history for those who came off. And on the target symptom, those who were medication compliant, in the 10, 15, and 20-year follow-ups, 75% were still actively psychotic. Now, they're on their drugs. How about those off medication ever since year 2? Only about 25% still have psychotic symptoms. And by the way, the time that their outcomes diverges between year 2 and 4.5, in the first 2 years, even those who've taken themselves off, say after a year, they're really still pretty troubled at the end of 2 years. There really isn't much difference. But then you see this extraordinary divergence between the 2 groups. And so what you're seeing there is a natural healing process, because these are people who are leaving care. It's not like they're getting supported for this. They're going against doctors' orders and they're doing it on their own. But that's a vision that doesn't show up in the short-term studies about this long-term course and this long-term possibility of healing. So we have that study. We also now have a randomized study down in the Netherlands in which they took people who had stabilized well. Half were put on a discontinuation or tapering arm, half maintained on drug. At the end of 7 years, the recovery rate was 2 times higher here. We also now have rat studies that have looked at this dopamine supersensitivity problem, and they show that it's a crazy model, but basically, they have a way to make rats behave what they call psychotic, right? They give them a drug, it works for a while, and then they say that drug causes the very dopamine supersensitivity that you see in humans, and then the drug stops working, even though the insult remains. Or even if the insult is taken away, that causes that, like amphetamines, et cetera. In other words, they say these drugs cause a breakthrough supersensitivity. We also have MRIs now that show over time these drugs cause the brain, antipsychotics, to shrink in volumes. And as that shrinkage happens, you get increasing cognitive dysfunction, worsening negative symptoms, and some worsening psychotic symptoms. So what we actually have in science now is a pretty good story about how antipsychotics on the whole worsen the long-term course of schizophrenia, including psychotic symptoms. And just one small thing, if you look at the place in the world today that has the best outcomes for first episode psychotic patients, it's in northern Finland, in the Western world. And beginning in 1992, they adopted a program where they tried to minimize use of antipsychotics, not put people on the drugs right away. 67% of their patients have never been on antipsychotics at the end of 5 years. And at the end of 5 years, 80% of their first episode patients are asymptomatic and working and back in school. So that tells you that if you look at this science and really use it to guide your care, you can do something much better. So that's a story about antipsychotics. I can tell you, if I could tell you a story about stimulants and ADHD, they also do not produce good long-term outcomes. So what we see time and time again is drugs that increase the chronicity of the disorder and people coming up for a biological explanation for why that is so. And finally, going back to the rise in disability numbers, one of the problems with antidepressants is they can stir manic symptoms. So you go on an antidepressant, you have a manic episode, and next thing you know, you're diagnosed with bipolar. And once you're in bipolar, you're in a much more chronic condition. Stimulants in kids can also, they have the risk of causing psychosis or mania or mood instability that gets diagnosed as bipolar. So if we look long-term at the use of these medications in the scientific literature, here's what you find. Yet there are some people who do well on them long-term, okay? But on the whole, you see that the drugs increase the chronicity. That's one problem. Decrease functioning, you'll see increasing disability rates, and they have the potential sometimes to take a person with a mild problem, like say a depressive episode, which could be due to a loss in life, et cetera, and turn them into a bipolar patient, a mood instability, which is a mood instability seen as a much more serious disorder. You get diagnosed with bipolar and you're often put on mood stabilizers, sometimes antipsychotics, and you're in a much more sort of difficult spot. So that's the literature that you see in the book Anatomy of an Epidemic, and I hope it's very well sourced, okay? So now the question is, why don't we know this? Why isn't this the narrative that we're organized around, some short-term efficacy and drugs that cause these changes? Well, that's what this new book is basically, Psychiatry Under the Influence is supposed to examine. So after Anatomy came out, I was invited by Lisa Cosgrove, who is a researcher at the University of Massachusetts, Boston, who does research on the conflicts of interest between pharmaceutical companies and psychiatry, to look at psychiatry, the institution of psychiatry, through a lens that was being developed at this Harvard research lab set up to study institutional corruption. So real quickly, the lab and then what we found when we put psychiatry into this lab. So the lab was funded by Larry Lessig. He's a former dean of the Stanford Law School. And here was his classic example of institutional corruption. He looked at Congress. Now, what is Congress supposed to do? It's supposed to serve the people, right? We elect them. But he says they don't serve the people anymore. Why not? Because they have to raise money from lobbyists to run. And because of that influence on them, they start serving the interests of special interests. So that's an example of an institution that has a public duty that because of an influence, a financial influence, that its behavior becomes corrupted. So now we're going to look at psychiatry through this lens of institutional corruption. So what are we going to try to do? We're going to try to identify the financial influences that act on the members of that institution and cause them to betray, in essence, their public duty. Now, we all know what the public duty of a medical specialty is, right? What do we expect of a medical specialty? To care for us, to care for the public, to always put the patient's interests first, not the interests of pharmaceutical companies and not their own guild interests. And one of the fundamental principles of modern medicine, and I think it was Irving who mentioned this last night, that came out of World War II in the Nuremberg Code, is informed consent. If you practice medicine on a person, if you do this, you have a legal obligation, actually, to give that person all the information necessary so they can consent in a reasonable way to that medical therapy. So that provides a standard of what we expect from a medical institution. We expect them to be honest in their information they give to us. So how did psychiatry become so corrupt? So here's what we do in this. We look at psychiatry's behavior since 1980, and the reason we go back to 1980 is because that's the year that the American Psychiatric Association published the third edition of its Diagnostic and Statistical Manual. And this becomes a huge sea change in how they're going to conceive of psychiatric disorders. If you look at the first two manuals, one in 1952 and 1967, there's a lot of Freudian influences, which say that psychiatric problems have like a psychological component to them. They're basically often a failure to adjust because of unconscious urges, et cetera. It's psychological. But then what happens in the and by the way, if you look at the history of psychiatry, it's Freud that allows psychiatry to leave the asylum. So psychiatry as a profession goes back to the 1850s, and it's superintendents, it's doctors who take care of mental hospitals. That's the roots of psychiatry, as superintendents of the severely mentally ill in mental hospitals. And basically for the next 90 years, that's where psychiatrists mostly practice, in the mental hospital. Then Freud comes along, and Freud becomes popularized after World War II. He popularizes talk therapy, and talk therapy allows psychiatry suddenly to say, oh, there's all these sort of people out in the community with problems that we can now tend to on our couches. So now it's that which allows psychiatry to leave the asylum and now have a much larger market, the ordinary people, so to speak, with more ordinary problems. Okay? And as they move out, the idea, of course, is of neuroses, right? That was a Freudian term. Someone could be neurotic, but the beauty of neuroses is you're all a little neurotic, okay? It's not, the idea of being neurotic is not over here are the ill and over here are the well. It's just that we all have degrees of neurosis, etc. But go to the 1970s. What's happening to psychiatry? Well, it is having its legitimacy challenged in many ways. There's some challenge of even what it's doing to people in the asylums, as maybe they're serving more of the social control arm. But even more important, in their talk therapy, insurers are saying, well, I don't understand your diagnoses, and I don't really see if they don't seem very reliable, and I don't really know if your therapies work, so why are we paying for them? And in addition, they're in competition for those patients with a lot of other groups, psychologists, social workers, and people just doing other types of therapies. So like in 1973 at a meeting of the APA, there was this worry. We are headed for extinction. What's our advantage in the marketplace compared to all these other talk therapists? And people say this, you start to see this. Well, we have one thing that the others don't have. What do we have? Prescribing powers. So if that is our advantage in the marketplace, prescribing powers, what do we need to look good in the marketplace to make that prescribing power valuable? you've got to have drugs that are worthwhile. And two, it will really help if you have a conception of all these people you're treating out in the community that they're not just neurotic, but in fact they have illnesses, because we prescribe drugs for illnesses. So in 1980, they published the third edition of the Diagnostic and Statistical Manual, and it is when they reconceive of disorders. They said, yeah, there used to be these psychological components, but we're now going to treat them as diseases of the brain. That's our conception. Now, it was, if you really read, they said these are hypotheses, and hopefully we'll do research that validates these hypotheses, and we'll find chemical imbalances, etc. But this is a new conception. It's a big sea change. They're going to conceive of depression, anxiety, and misbehavior of kids in schools as diseases of the brain. And now, okay, that happens in 1980. So, this is the moment we start to look at in this book about how psychiatry falls under the influence. The first thing we want to do is to identify the growing influence of the pharmaceutical companies once they adopt this new conception. And the minute this happens, the drug industry starts flooding the APA with dollars. So, for example, the annual budget revenues of the APA in 1980 were $8 million. By 2008, it was around $65–70 million. And what's happening is the minute this conception has, the drug companies, okay, at the annual meeting, they're setting up their big shops, right? They also begin sponsoring symposiums at the APA, scientific symposiums, where it's being taught by, the courses are being given by academic physicians, so it seems like science, but those symposiums are actually funded by the drug companies. They pay like $50,000 for every time they have a symposium, so there'd be these big ballrooms, 1,000 people of psychiatrists, everybody getting a free lunch or a free dinner, and then someone comes out here from Harvard, and he says how wonderful these drugs are, how valid this disorder is. So it looks like you're getting a scientific speech. In truth, those speeches were rehearsed with the drug companies, and they were being paid for by the drug companies. And not only is the drug companies paying the APA to give those talks, they're paying me to give those talks. Anyway, so we chart this money that goes from pharmaceutical companies to the American Psychiatric Association, and they begin funding everything. They begin funding public relations campaigns for the APA. They begin funding internships, fellowships. They begin funding, I already mentioned the PR campaigns. I mean, they began funding a campaign to train psychiatrists in what to say to the media. So you just see this flood of money from pharmaceutical companies. That's one flood of money into the APA. The second thing is they begin buying the academic psychiatrists. So before 1980, academic psychiatrists had this sense of you've got to stay away from drug companies somewhat. But now it changes. And by the way, psychiatry is saying we're going to put on a white coat, like we're in internal medicine. We treat the symptoms of a disease, so they have a new image they're presenting. It's no longer the shrink by the couch, it's an internal medicine doctor. And you can see in the archives, they say, how do we improve our image with the public? We wear a white coat. That's the image of the doctor. So this is part of the change as well. But what happens now is 1980, they conceptualize psychiatric disorders as illnesses of the brain, and they have, at that very moment, the APA says we'll start allowing these symposiums at our annual meeting, say on anxiety disorder or depression, and they'll have these famous people up there with academic credentials, and they're going to start paying me to give those talks. And not only will they start paying me, as the great psychiatrist at the medical school, to give these talks, they will start paying me to be an advisor, consultant, etc. Help them get their drugs to market, test, and I just want to give you an example of how some of the money that flowed to individual psychiatrists. Joseph Biederman, he helped eventually open up 2 markets. He's from Harvard Medical School. He's at Massachusetts General Hospital. He really helped develop the market for ADHD and the use of drugs, and then the market for juvenile bipolar. One company, Janssen, who was marketing Risperdal for kids, for juvenile bipolar, paid him $1.6 million between 2000 and 2007. Now that's one doctor for one company. If you actually look at his disclosure list, I think he eventually worked for about 24 companies. How about Frederick Goodwin, former NIMH director? He helped open up a market for the use of a mood stabilizer for bipolar disorder. GlaxoSmithKline paid him $1.2 million between 2000 and 2008. How about AstraZeneca paying Melissa DeBello? She was helping open up a market, I think it was for an antidepressant for kids. She got paid $418,000 over a course of 4 years. My point is the money that was going to the big academic psychiatrists for advising, speaking, and they began to speaking to other doctors, it was really considerable money. Now, how big did this influence become? By 1998, the New England Journal of Medicine was trying to do a review of the efficacy of antidepressants. So they searched the experts in mood disorders, and they said, we need someone who doesn't take money from drug companies to do this review. I said, well, we can't find anybody. The point is, academic psychiatry at a time practically got bought completely. So now if you think about this, you have a trade association that's getting money from pharmaceutical companies. And more important, the very people we look to tell us the truth, to be the experts, they're getting a lot of money from pharmaceutical companies. Now, as that happens, you see why they're maybe not going to tell us about drugs that make things chronically worse? That's not what that influence is meant to do. And then there's another influence, though, that I think goes unrecognized, that in some ways I think is even more pernicious than the pharmaceutical influence. It's psychiatry's own guild influence. So psychiatry as a profession, when it adopts this new disease model in 1980, you know what it says? You start reading, if you go in the archives, they say, we've been squabbling among ourselves now for a long time about the nature of mental disorders. We have the Freudians, and we have people who believe that social injustice and problems are the problem. And then we have the biological guys, that these are disorders of the brain. And basically they say, hey, the biology guys won. Time to stop arguing about the nature of mental disorders. Get behind with the united voice behind this one vision, that these are diseases of the brain. 1980, you know what they immediately do? They they set up a new division of publications and marketing. They enhance their PR efforts. And now, with great regularity, ever since 1980, the American Psychiatric Association has been running public relations campaigns. And there's all sorts of ways they do it. Through brochures, websites, and the message since 1980 has been really consistent to the public. There was the chemical imbalance story, but it's also this. These are real diseases of the brain. They're under-recognized. They're undertreated. And we have therapies, drugs that are highly effective. Isn't that basically the message we heard? That's what we heard. And you know what? It was incredibly effective. In fact, they have 20% of the American population now on psychiatric drugs. Think about their influence now over society. We have kids left and right. They changed our society with this PR campaign. And it's really interesting. If you look in some of the literature in which drug companies are talking about their influence over the academic doctors, these people that have such prestige in society, they actually say it's not so much the money, they think. I mean, the money's important. They say we can elevate the stature of these people. It's their ego. We can make them the world leaders in ADHD and fly them around the conferences. We can make them the world leaders in anxiety disorders. So they also understand that it's the ego involved as well. And if you have ever been to a psychiatric meeting, annual meeting, the people who are seen as the leaders in these disorders, they're treated like gods practically. There'll be a lineup for their books that'll just be like hundreds long. So there's this ego involved as well. So, what do you see in terms of trying to understand how psychiatry became what it was? You see pharmaceutical money going to the APA, that's the trade association. You see it going to the individuals who are the spokesmen out to society. And by the way, the drug companies ran they funded media education campaigns during the 1980s that trained psychiatrists what to say to the public, which was basically they're under-recognized, under-treated, and the drugs are fantastic. And they were taught, it was like a corporation basically knowing how to sell its product. All right? And that's how we get the chemical imbalance story, etc. So we see those influences, and then in this framework of institutional corruption, the idea is that behaviors become normative within that institution, and they no longer see themselves corrupted. So, you know the old adage, everyone's doing it? That's sort of an idea that you have a new normative environment. So if I'm a psychiatrist, and I'm at a medical school, and everybody else is getting money, well, I'm going to get the money too, and I don't see myself as corrupt. In fact, what I see is now I'm an expert like everybody else. That's what they tell me. I'm the world's expert in ADHD or whatever. So I'm not being bought. And if they do studies of people who take money from drug companies, that's, you know what they'll say? Doesn't influence me. I just tell the truth, basically. Now, it influences that guy over there, but it doesn't influence me. There's this sort of cognitive dissonance that goes on. And so the idea is that the people within the institution become somewhat blind to their own actions. And then when they're confronted with data, such as poor long-term outcomes data, that threatens the whole story they're invested in, they'll have cognitive dissonance to sort of to say why we can disregard this or that sort of thing. So the next question is, well, what's the corruption we've seen? So you have these influences that are acting on the behavior, and what sort of corruption do we see in psychiatry since 1980? Well, first, let's just go about what we're told about the validity of psychiatric disorders. If you look in medicine and you have a diagnostic manual, that diagnostic manual is supposed to confer two things. Diagnostic reliability, meaning if I go to two different doctors, they'll give me the same diagnosis. Hopefully, my diagnosis is going to stay stable over time, which means I have a distinct disorder. And your diagnosis tells of a valid disorder, okay? In other words, it's real. Now, how do you validate disorders? Well, the best way to validate a disorder in the public mind is identify the pathology, right? That means we've shown that you have low depression, low serotonin. So when you think about the chemical imbalance story, part of what they were doing was validating these disorders as real brain diseases in the public mind, and therefore validating the whole DSM-3 model, the disease model. That's what they were doing. And you can hear claims about this being made to the public. These are real brain diseases, we've validated these disorders, et cetera, et cetera. But in truth, they weren't finding chemical imbalances. And they weren't finding, in fact, the other types of data that you can use to validate disorders. And that is things that, where you have this diagnosis only responds to this drug, another diagnosis only responds to this drug, it stays stable, you find some genetic associations, you can chart the course of this disorder, it's different from this disorder long term. And there was criteria actually set out in the 1970s by a St. Louis group is, how can we validate these disorders? Now, you were told they were validated. I'm going to just tell you, I'm going to just read a couple quotes from a meeting of psychiatrists while they were doing the fifth edition of the latest updated edition of the DSM. These are the experts in diagnosis. Okay, I'm going to just read you some quotes because we've been told they've been validated. Here's Alan Francis. He was the head of DSM-4. DSM disorders no longer seem at all reducible to simple diseases, but rather are better understood as no more than currently convenient constructs, okay, or heuristics that allow us to communicate with one another as we conduct our clinical research, educational, forensic, and administrative work. Here's another one. While in principle, science should be the basis of any diagnostic system, DSM has been seduced by the illusion that advances in neuroscience provide empirical validity for a new system. That's the disease model. In reality, we do not know whether conditions like schizophrenia, bipolar disorder, or obsessive-compulsive disorder are true diseases. This is in a roundup of psychiatrists who are experts in diagnosis. Then listen to this one, Nasser Ghami. He says, when I graduated a generation ago, I accepted DSM-4, that's the fourth edition in 1944, as if it were the truth. I trusted that my elders would put the truth first and then compromise for practical purposes where they had no truths to follow. It took me 2 decades to realize a painful truth, spoken now frankly by those who gave us DSM-3 when Ronald Reagan was elected, and by those who gave us DSM-4 when Bill Clinton was president. The leaders of those DSMs don't believe there are scientific truths in psychiatric diagnosis. Only mutually agreed upon falsehoods. They call it reliability. So the point here again is this. So I'm a journalist, right? You have a public story. Then you go behind the scenes, the public stories, these are validated disorders. We found the causes of them. These are true brain diseases. We know that. And then you peek behind the curtain where the people themselves are talking about the validity and said, we didn't validate these disorders. Very different thing. So that's an example of the corruption. Then you look at drug testing. And let's say, and one of the first drugs they test when this comes on after DSM-3 is Xanax, alprazolam for anxiety disorder. You all heard about Xanax? Well, you didn't at the time it came to market, though. So Xanax was actually, we had the old benzodiazepines, Valium, et cetera, and they were known to be addictive in the 70s, and there was warnings about don't use these drugs too long. And then Xanax comes along, and it also gets approved. It becomes the first drug approved for a newly identified disorder in DSM-3, panic disorder, okay? So you look at the studies of panic disorder. And they were very proud. This was, even though it was funded by Upjohn, it was really academic psychiatry said, we're going to take control of this study. Okay, it was an 8-week study. We're going to either have people with panic attacks, half are going to go on drug, half are going to go on, I guess, just placebo. And then after 8 weeks, because we know these drugs shouldn't be taken long-term, we're going to withdraw patients, okay? So we know we're going to have withdrawal end, and we're going to be able to show that we can withdraw people safely. So, 8 weeks. It's an 8-week study. What data do they report? The 4-week data. You know why they report or they highlight the 4-week data? Because after 4 weeks, there is a great reduction in panic attacks after 4 weeks. The drug looks really effective. But that's not the end of that's not even the end of the acute period. By the end of the acute period, it was no difference between the two. Okay? Now they withdraw people. And what did they find in the withdrawal time? Things went to hell for the drug-exposed patients. There was, I forget the numbers, but there was a significant percentage who couldn't come off. The withdrawal effects are so bad. So you see in that group, a group that is now addicted to the drugs. The people who tried to come off, they had an explosion of panic symptoms, such that by the end of the study, they were suffering something like, well, they were worse than they would when they entered the study, and 4 to 5 times many panic attacks as the placebo group. So now what do you, the population, make of that study? Should you use Xanax? Bad idea, right? You get addicted to it, and when you come off, you're worse than the beginning. Did they publicize the results at the end of the withdrawal? It's in the data, but you really have to dig to the data. It's not in the abstract. They actually report in the abstract there's really no difference, but it's just not true. You can look, and in this book I chart out the difference in panic attacks. Why do they do that? Why don't they report that? Why isn't that in the abstract? Because you can't sell Xanax if that's in the abstract. That's an example of how now, under the influence, what the stories we were told about drugs stops being truthful. I'll give you 2 more quick examples. If you look when the SSRIs come up into market, you heard from Irving yesterday about how really they're not much more effective than placebo. It's very minimal. That shows up like crazy in the data right away. In fact, in Prozac, you actually see data that shows Prozac is not as effective as the old drug on many studies, as imipramine. You see the FDA in its review saying, well, Prozac's really not very good here. Maybe it's a little better than placebo, but it's not as good as imipramine. Did that review get into the scientific literature by doctors who now are working for drug companies? No. Instead, we heard that the Prozac is at least as effective as imipramine and safer. So that's an example of a perversion of what is reported. You can see this time and time again with antidepressants, with the new antipsychotics. You can see that trials are biased by design, the results are spun, that sort of thing. But those are industry-funded trials. Surely the NIMH-funded trials, funded by the government, when these people are not working under the with the drug companies, maybe they'll be more honest. Pharmaceutical influence is not there. Well, I will tell you, I think the distortion of science in the NIMH-funded trials, which had a longer look and were seen as meant to guide care, are more perverted than the industry-funded trials. And I'll give you 3 quick examples. ADHD. By 1992, it was acknowledged, now we've been medicating kids with stimulants for at least 12 years by now, a little bit more, that there was no good evidence that stimulants provided a benefit on any domain of functioning over the long term. So you can see, this is even admitted in a psychiatric textbook. They says we have no evidence that there's lower delinquency rates, better educational achievement, better educational employment when we give these kids these drugs. So what do? They mount a study called the MTA study, the multi-site multimodal trial. And when they mount this study, they say, this is the first good clinical trial of any pediatric disorder in psychiatry. And this is the study that's going to tell us whether we're helping kids grow up and thrive. This is it, okay? And then you go to when they announce the study, they say, at this point, we have no evidence that stimulants provide any improvement in any domain of functioning over the long term. Okay, now in my opinion, the study was biased by design, but I won't get into this. Here's how the study goes. Kids are randomized into 1 of 4 groups. Drug alone as prescribed by experts in ADHD. Drug alone as prescribed by people in the community, ordinary clinical care. And I think there was drug plus behavioral therapy and behavioral therapy alone, okay? And what they announced is after 14 months, the kids treated by drugs prescribed by the experts, they have a greater reduction in their ADHD symptoms, and there's a hint they're doing better on reading too. Big announcement. We finally have evidence that these drugs provide a long-term benefit. And if you go on the web today and you're a parent searching for this and you pick out a guide by the American Academy of Child Psychiatry, I think it is, it will say, how do we know these drugs work long time? They'll cite this study, the 14-month results. Okay? This is what's guiding our understanding. What they don't cite is the fact that that study continued. And what happened now, at the end of 14 months, it's just naturalistic. If you've been on drug, you can go off. If you haven't been on drug, you can go on. But they're just going to chart people, and they're going to look at medication. And by the end of 3 years, the researchers announced something startling. If you really dig into it, it's not in the abstract. What do they announce? That by the end of 3 years, medication usage is a marker not of benefit, but of deterioration, even on the core ADHD symptoms. And now what really is happening is the non-medicated kids are continuing to get better, whereas the medicated kids are sort of stagnating, even on their ADHD symptoms. But a marker of deterioration. Was that in the abstract? No. Did you have to read the paper really clearly to get that? Yes, you did. Has that been announced to the people? Does any parent, when they go on, are they told about the 3-year results? They're not. How about the 6-year results? 6-year results are these. Greater ADHD symptoms, greater delinquency rates, a greater sort of functional impairment, all in the medicated kids. As one researcher, who's a psychologist who was involved, said this. He only said it in the UK. He won't say it here because he's afraid of his funding. He said this, William Pelham. We had thought that the medicated kids would do better. That turned out not to be the case. We found no benefit on any domain of functioning. We found that it would help their kids behave better over the short term, but not in the long term. And that should be made very clear to parents. Now, that's the psychologist. By the way, there's some data showing that the psychiatrists on that who really ran the study did not even really want to present this data. They were unhappy with it, and they certainly were not unhappy with him for saying this. So, yeah, just one second. They also, by the way, were 6 times more, I think it was, I'm going to get this wrong, but there was a much greater risk that they were anxious and depressed, the medicated kids as well.
What was the one that used to say that kids that went on Ritalin, that made them shorter?
Oh, that showed up too.
Why is that?
Because I don't know exactly, but it's an appetite suppressant. Ritalin is an appetite suppressant. But they found people being shorter too. And at least in this study, they did not find catch-up growth over time. So, and this goes to the point. They had a long-term study. There's nothing of benefit on any domain. You just have the risks that are left, and the risks include converting to bipolar, et cetera. But is that communicated to the public? It's not. Is it in the psychiatric textbooks? It's not. Is it on the websites by the APA, the NIMH? It's not. That's the problem we have. That's what I mean psychiatry under the influence. It doesn't tell us the real story. Two more quick stories. One of the things we then look at, and then I'll go, no, why don't I stay on the studies? So they build a market for, as they go through the antidepressant market, initially they go with adults, right? By the early 1990s, the companies, though, were saying, the adult market's getting saturated, we need to sell these. What's an untapped market? It's the kids. Okay, so they made a campaign now to start selling antidepressants to kids. Now, one of the problems they had at this moment was that it was understood at this point that kids really didn't get depression. They got moody, but they didn't get clinical depression. So now you see some American psychiatrists who are going to be highly rewarded for this saying like, we used to think kids didn't get clinical depression, but now we know they really do. Okay, now that sets them up as a market. Then there's someone named Martin Keller from Brown University. He says, and I forget which company. I think it might be SmithKline Beecham. I'm not quite sure, but he says, listen, I'm going to test your drug in children. I'm going to show it's effective, and this is going to be the greatest database ever shown about antidepressants effective in kids. He does this. Someone does it for Prozac's drug, fluoxetine. And what do they really find when they do these studies? They just generally don't work in kids. In other words, they're not even effective over the short term. And what eventually comes out is that of the first 7 companies that looked for labeling, pediatric labeling, 6 were denied by the FDA because the studies weren't showing efficacy. There had been 15 studies submitted to the FDA and 12 were negative at that time. But what did you see if you looked at the research literature? These were effective. The very studies that were being shown negative into the FDA were being instead being presented to the public as effective. Think about the betrayal of that. Then we get a black box warning, okay? And because there's a risk that these drugs are increasing the risk of suicide in kids, and the data seems pretty solid on this, or at least suicidal ideation, the FDA puts on this black box warning. In the UK, they basically ban all SSRIs in kids except for fluoxetine, Prozac. Now, in my opinion, the trials in Prozac were so biased by design against kids, it's ridiculous. But then we do an NIMH-funded study of Prozac in kids and teenagers. And there's 2 things that I think. It's really effective in this one, much more than any industry-funded trials, which you have to ask why. Well, you can find that, in fact, it was unblinded, so that makes a big difference. And then they report this. There's no excess suicide risk in the drug-treated kids, okay? And this resurrects the prescribing of fluoxetine to kids. There's no excess risks. We did a careful study, and they report that there's 9 suicide attempts in the placebo arm and 9 in the drug arm. Or there's what there are 4 arms. There's CBT alone, CBT plus drug, placebo, and drug alone. So the CBT alone is in the non-drug group. So no excess suicide risk. So I'm not the one who discovered this. There was a Swedish psychiatrist who wrote and said, you know, you need to look at this table on the suicide reports. And if you look at this table carefully, you'll see a totally different story. Do you know in that study, in fact, 17 of 18 suicide attempts were in kids on SSRIs? Only 1 not on drug. So how do they tell us that there's no excess suicide risk? How'd they do it? Here's how they did it. You get randomized to placebo for 12 weeks, right? Then after 12 weeks, what they wanted the placebo group was to go on drug, okay? So they encouraged them to go on drug. Same with the CBT alone group, basically. They encouraged them to go on drug. Now, what happened is, in the CBT alone group and the placebo group, there were 8 kids in the next 24 weeks that tried to commit suicide, made a suicide attempt. But those suicide attempts were reported as due to the CBT alone group or the placebo group. So in other words, they got chalked up back to that randomized group even though they were on drug. Now, if you read the study carefully, it's there. The data is reported. There's this table where you can figure this out. You can see. They actually do report the data. But do they discuss it? Do they summarize it that way? Is that what's in the abstract? No. Now, if you want to look at the betrayal, I know mothers following that study whose kids went on Prozac, were told that there was a study that showed the drug was safe, and those kids committed suicide. Now, what do you think those mothers think about this? Finally, I mentioned the STAR-D study. The STAR-D study, largest antidepressant trial ever conducted. It was meant to guide long-term care. At the end of 1 year, out of 4,041 patients, only 108 had remitted, stayed well, and in the trial. That's a documented stay well rate of 3%. Is that data in the abstract? No. There's a table, but you can't figure out the table. It took a psychologist named Ed Piggott to look at the protocol and get freedom of information requests to finally make sense of that table. So why can't you make sense of that table? They're hiding the data, right? Anyway, I've just got 4 minutes left. My point here in this book is this, which I co-wrote. We have organized ourselves as a society around a false narrative. It's a narrative of progress. It's a narrative of validated diseases. It's a narrative of drugs that fix chemical imbalances. It's a narrative of drugs that are highly effective. And because of that narrative, we medicate our kids like crazy. Of course, we're medicating the population like crazy. We spend so much money on these drugs and on this approach. And now think about the social injury. Just focus on the kids for a second. On the diagnosing of kids with ADHD and putting them on stimulants. It's going to change their brains. We did research. It showed no improvement on any domain of functioning. In fact, it shows negatives. Shouldn't we be telling parents this? And isn't there an obligation to kids to tell them this? You see the betrayal of the kids in this? Anyway, when we try to document in here the social injury, it's given us a false sense of being, where we have this reductionist sense of ourselves, right? It's also an impediment to social justice. Think about it. It's not socially unjust things. It's not poverty. It's not lack of opportunities. It's not like, people struggling to make a living with wages that cause problems. The problem is located in the individual. It removes any responsibility for us to create a more just society. And you know who you really see this with? The foster care kids. So foster care kids, what has happened to them? They've drawn the short straw in life, right? And we know kids need to feel safe. They need to be nurtured. They need to be loved. Foster care kids so often grow up in environments where that is missing. So what do we do today to foster care kids? The problem is you. You've got ADHD or you've got bipolar and you need to be on antipsychotics or these drugs. So think about that. It allows us to always blame the individual and not try to take a societal responsibility. So we get this philosophy of being that's out of sync with literature, where we don't think grief is normal, distress is normal. Anyway, the social injury, I think, is vast. And then we look, why doesn't psychiatrists realize this? Why don't they see themselves in this light? And that takes you into a study of cognitive dissonance. And one of the things we did for this study is just look at the story psychiatry told to themselves since 1980, as told by the heads of the APA in their annual talks. And here's what you find. We are doing incredible research. We are doing some of the most amazing research that has ever been done. So they say, it used to be that we weren't treated as real doctors. Now we're respected as real doctors. And we're people that treat the most unfortunate societies, and we're heroes for that. So what you see in this self-image is of people who are real doctors, who have done amazing research, and are a force for unbelievable good, relieving distress. And I think that's how they do see themselves. And if you want to see this on display, the former president of the APA, Jeffrey Lieberman, has a new book out called Shrinks, The Untold of Psychiatry, and it's all about, as he says, modern psychiatrists as heroes. So that's how they see themselves. And then when they get data that confronts that self-image, of course, what do? They blame the messenger, they kill the messenger, they say there's a problem with this study, they hide the results even to themselves. And therefore, within that institution, they still have this narrative alive. And so the final thing is, what do we as a society do about it? And you can see the challenge, because if we as a society are organizing ourselves around a false narrative that's doing damage, we need to think about how do we build a different societal response to emotional distress, whatever we want to call it. Because it is true that kids have troubles, you and I have troubles, people have troubles, and there are some people with severe troubles. So there is a societal responsibility. So how do we repair this narrative, this false narrative that is doing such harm to our country? And I don't know the answer to that. I just know that we need to do that. And this conference is about the real truth about health. This is a little niche in which you see there is an extraordinary chasm between what we've been told, the narrative that drives our care, and the science. And that chasm is doing great harm to all of us, and including how we raise our kids. So, thank you.